Good afternoon, everyone, and let's get started. It is truly my distinct honor to introduce you to Professor Kathleen Sutcliffe, who's a Bloomberg Distinguished Professor, has joint appointment in the School of the Business School, the School of Nursing, and the School of Medicine. This is a third installment of a lecture series offered by Bloomberg Distinguished Professors who introduce the Johns Hopkins community and beyond topics of importance, challenges facing society, challenging faced by society, and this is no exception today. But before that, I'd like to give a short introduction of Professor Sutcliffe, who's really a remarkable path. She got a bachelor degree at the University of Michigan, got a bachelor, that was in arts, Bachelor of Science in the University of Alaska, because why not? A Master's of Nursing at University of Washington, you can see a theme here. A PhD in management at the University of Austin, and I understand was just recognized as a distinguished alum just a week ago. But that wasn't enough, of course. Dropped all this and said, I'm going to have to learn things, how it happens, on kind of ground level. Actually worked on a crab boat in the Aleutian Islands, again, because why not? Was a laborer on the Alaska pipeline. I think those experiences can form you, can make you stronger if it doesn't kill you. These were obviously very physical exercises. Actually, Professor Sutcliffe is a world sommelier in organization and in understanding of how big organizations can take measures to address issues of unexpected events or certainty, and with a focus on reliability and resilience. A lot in the healthcare business, but not only. And we asked if she would be amenable to, sharing with the community some of her ideas about patient safety, and it turns out. Professor Sutcliffe is writing a book. I think it's going to be a very important text about hospital management and the issue of patient safety. So without further ado, let's welcome Professor Sutcliffe, who is going to talk about patient safety through the eyes of an organization theorist.
Great.
Thank you so very much for agreeing to do this.
So welcome, everyone. Thank you for being here. It's obviously my honor to present to you today. And I took my assignment as thinking that I would present just a flavor of the kinds of research that an organization theorist does. I have studied many things in my now getting very long academic career. I have studied top management team demography. I've studied top management team cognition and decision making. I have studied dysfunctional momentum in wildland firefighting and in the oil and gas industry. And most recently, I am studying resilience in adventure racing teams, which has been a really interesting study. And we just interviewed 110 adventure racers, and I learned a lot about resilience. But today, I want to talk about another domain of my research, and that is the research in the area of patient safety. And I think the operative thing up here is to take a look to really see the term organization theorist, because if there were people from healthcare services research or people from medicine, they would have a different lens on what we're going to talk about today. And I am going to give you my lens as an organization theorist. And the way that I'm going to do that, specifically what I want to do is I just want to give you a flavor of what that work looks like. And then I want to talk a little bit about where I think we should go with with this kind of work if we're taking an organization theory perspective. And I do want to start out with a case. And that case comes from some research that I did with a collaborator on emergency departments, and that collaborator was Dr. Robert Weirs from the University of Florida. He was a physician, and he was a rock star in the area of patient safety. Unfortunately, he died an untimely death last year. But we started this work a couple of years ago, and it was a multi-method study of emergency departments, and we studied multiple emergency departments. We published a few papers on this, and it included an intensive component. It was a qualitative component, intensive interviews, and in those interviews, among other things, we asked people to talk about the recent mishaps that they had experienced. And so we had several informants talking about the same case, and this is what they said. They said that that case started out beautifully. It was a case that went well from the beginning. It dealt with a 46-year-old male that was brought to the ED by the rescue squad. It was a possible drug overdose. And the person had a past history of depression, and they were somnolent, but they were arousable. And so the EMTs did not intubate the person. And it was a Monday, okay? It was a Monday, and if you're in medicine or healthcare, generally speaking, Mondays are really, really busy days. And in this particular context, there were already a whole bunch of people in the ED by the time the person was brought in. They had 5 medical intensive care units, consults that were pending. They had to move patients around. Although it was a very big urban emergency department, space was tight. And as our informant said, all the right things were done from the beginning. The labs were back within 30 minutes. Within an hour, they knew what was going on with the patient. They knew what the right thing was to do. And so the case started off beautifully, but what happened was they did a loading dose of the antidote, and that was the end of anything going right in that case. Because this is what happened. They didn't know what they were facing. As I said, they thought it was a drug overdose. They thought it was perhaps a Zyrtec or a Prozac overdose. And then they thought, well, maybe we should get a Tylenol screen. And in fact, it was a Tylenol overdose. And the protocol to deal with a Tylenol overdose is that you give a drug called NAC. And the protocol is you give a loading dose, and then you give 17 other doses of the medication every 4 hours after that. And so what happened, the loading dose was made, but that was it. The patient did not get any other doses of the medication for about 20 hours, okay? And as our informant said, we can never know really whether the person came in and already had some liver damage. But 2 days later, the patient died, okay? So, the question is, what happened? Our informants think certainly that that what happened was that the medication misadministration did play a role. But when we took a look at this particular case, what did we see? Well, we saw, first of all, that this was a consequence of a mindless system. While people were doing their individual jobs, they weren't thinking about the larger issue and the larger goal of the system, which was to provide care to a desperately ill person. Small jobs got done, but the goals of the system were not accomplished. And let me just highlight this and what was going on here, because I really think that our initial analysis showed that there were multiple interactions. And I think this is really interesting, because this just shows you that, just the primary interactions that were going on, there were about 7 of them. And that wasn't the interactions with the lab and with the X-ray and with all of the other parts of the system that had to be involved. And so what we saw is that there were these multiple pathways where information could become confused, where that the necessity and the timing of the subsequent doses of this particular antidote really did become lost. People didn't realize what they had to do. So people were doing their individual jobs, but they really missed the doses, and the authority and responsibility for ordering the medication became confused overall. But then when we dug into this a little bit deeper, we saw a number of things that happened. Number one, we saw that it was a very dynamic situation. So, of course, all of you who are in healthcare, and thank you, would know that, and if I just might ask, is there a way to get this on the screen? Because for some reason it's not here, and then I don't have to look up here, but anyway, I don't know why either, but anyway, okay, all right, thank you. So we know it's dynamic. It was a teaching hospital, and people in teaching hospitals are always moving around, and so it was incredibly dynamic, and it was an incredible day that was very dynamic as well. Lots of people were coming and going. The second thing we saw, though, is that there were lots of silos. What was interesting in this case is about a month before we did this data collection, we had done another data collection with surveys to get a sense of whether people knew each other in this emergency department. It was actually a very stable workforce. We know that the workforces in healthcare are unstable. People are constantly turning over, et cetera. But in this particular emergency department, they were stable. And at the same time, people very much just kept to knowing and talking with people in their own discipline. So we found, for example, that only 30% of the doctors knew anybody's names. So they didn't know the names of the nurses, they didn't know the names of the techs. It was remarkable, and actually they started an initiative after that to make sure that people knew who they were, who their coworkers were. So it was very, very siloed. We also saw that there were heedless interrelations, and what I mean by that is people were going about their jobs without looking at what other people were doing and how they joined together, but they were also just not thinking about the big picture. It was a context and it was a situation in which people overlooked small failures. There were a number of small things that went wrong. The patient was pushed to a part of the emergency department where nobody could see them, and that was a little mistake, and there were other things as well. People simplified the task at hand. This was just going to be just give medication and everything will be okay. That was what we were supposed to do. It was a very busy day, and the hospital was not attentive to the demands on the front line. Some people were missing that day, and so really there weren't as many staff available to be watching out for things as was needed, which meant that there was no capability to bounce back. When these people faced all these pressures of having so many patients, it was really difficult to be resilient. And we also found that this was an organization that valued hierarchy and authority over what was happening on the front lines. And so, it was actually pretty interesting to dig deeper into the situation. Now, you might be saying, is this atypical? Is this typical? I personally think that this is typical. We know that patient harm comes in many forms. It ranges from big to small. It's things that were done, things that were not done. In this case, things that were not done, doses of medication that were missed, not given on as necessary. In other cases, wrong things are done, wrong site surgeries, wrong medication, wrong labs, etc. And so, generally speaking, though, we know that patient harm or harm to patients is a big deal. I think about patient safety as the, okay, I'm going back, I apologize. Just as this avoidance of harm to patients from healthcare. And what's interesting to me is people think that this attention to patient safety really has grown, or that it really took off, that it wasn't a concern to healthcare or medicine before 1999 and 2000, when the Institute of Medicine published a report called To Err is Human. That was really a big deal. But if we look at, if we look at this Google Ngram example, you can see that since, throughout the last 100 years or so, that there has been varied attention to safety. And in fact, if we look at this, we see that it did rise about, I think this is 1960 there, I think, and then 1980, 2000. But if you take a look at the 1800s, we see that there was attention to safety then. Around 1847, Semmelweis documented the risks of medical treatment across 2 wards, and that's pretty famous. In the 1990s, as we see, Codman, who was a surgeon, designed a classification system to classify the reporting of surgical errors and surgical mistakes. In the early 1970s, around the time that things were starting to really take off, in the early the early 1960s, Moser came out with a book on the diseases of medical progress. And then in the 70s, Jeff Cooper and Ellison Pierce published some works on anesthesia. Anesthesia was kind of the precursor or the forefront of thinking about safety and how medicine and healthcare could be made safer, especially in anesthesia. And then, of course, in the 1970s, there was the medical insurance feasibility study that was conducted in California. There was the Harvard medical practice study that was conducted at Harvard. And then there were Annenberg conferences. And then there were a whole bunch of narrative stories about patients who were harmed. The stories that kind of stand out for me, a story about Libby Zion, who was a young freshman at Bennington College who had a father who was very famous in New York. He was a famous lawyer, I believe. And she was harmed when she went to the hospital with flu-like symptoms, and she was given the wrong medication. She was given the wrong medication by residents who were overworked. And as a consequence of her illness and her untimely death, her father got these resident rules where residents can't work for more than a certain number of hours. But in any event, there was Libby Zion. There was Betsy Lehman. Betsy Lehman was a Boston journalist who was undergoing cancer treatment in a Boston hospital, and she got too much of that, and then she died. There was Willie King, actually. He was a heavy equipment operator in Tampa, Florida, who was supposed to get his leg removed. He was a diabetic, and they took off the wrong leg, and then they had to take off the other leg. And then, of course, there was Josie King here at Johns Hopkins in 2000. So this was a time when there was a confluence of activities, a confluence of stories, a confluence of studies, all of these things happening to really raise the attention to patient safety, but clearly attention was being paid before that. Because if you look at it, this is a list of the most common sources of harm in medicine, and maybe one of you would hazard a guess as to when this list was first published. Anybody? What do you think?
In the 1800s.
Okay, you probably have seen this before.
I have not.
Okay, all right.
I've just experienced a lot of ED departments.
Okay.
That's why I would say that.
Okay, in the 1800s, yeah. Okay, because I was going to put up the rest of these things that were included in the list in this particular article, like planetary influences. But we do know that people, studies do show that people are in cars are less safe after daylight savings, right? So planetary influences actually do play a role. But anyway, if you look at malaria and other things, this did come from the 1800s. It did come from a paper that was published in 1846 in the Boston Medical and Surgical Journal. And what I want to point out to you, if you can read the fine print here, I love that this says, the same causes and sources, and by the way, the Boston Medical and Surgical Journal is now JAMA, the Journal of the American Medical Association. But I love this thing, the same causes and sources of error in medicine that obtain at the present day prevailed in ancient times, or rather have prevailed in all ages. So, I think this is, I love this just because, it gives us a sense of the fact that medical harm and that the causes of medical harm might have been similar. So we know that medical harm carries potentially catastrophic consequences for patients. In the last 20 years, there have been several attempts to try to assess the burden of harm, and in fact, there are variable estimates. I mean, in 1999, actually, in the estimates in the Institute of Medicine report were estimates that had come from earlier studies. There were no new data presented in the Institute of Medicine report. It was drawing on data that had been published like in the years before, but the estimates coming from that were 44 to 98,000 deaths a year. Jumbo jets crashing every single day, okay? Then in 2016, two Johns Hopkins University scholars estimated that looking at 4 studies over the last 10 years and that were published, that it looks like in 2016 about 200,000 deaths a year were taking place. It would be the 3rd leading cause of death behind cancer and heart disease. I won't say that these estimates have not been criticized, because they have. I don't think we really know what the burden of harm is. And I think it's a very challenging situation because, harm occurs not only in hospitals and in institutions, but it also occurs in outpatient settings and in home settings, et cetera. So it's very difficult to see what the harm would be. Still, should we need to think about it. We know that it matters. We know that providers are harmed as well, in addition to patients, emotional, financial, legal costs, et cetera. And we know that organizations are harmed. And we know that it's a big deal if your organization loses its reputation, and especially in a highly competitive environment that we're all facing. So it is actually a very, very big deal. But if we go back, you might be saying, so what? If we go back to our example of the vulnerable system, the example that I started with, I really think that, if you were a family member or simply an informed citizen, you may look at this example and say, well, it's just a matter of that one person or those 2 people who are supposed to give the medication. It's their fault. We would, if you were the patient's family, you would want to blame the people on the front lines. But from my perspective as an organization theorist, I think that this is a vulnerable system. And I have spent much of my academic career, as Denis highlighted, really thinking about systems and trying to answer the question, how do complex systems and organizations achieve safe, reliable, resilient performance under dynamic, uncertain kinds of conditions? And I think that question is really central to my discipline of organization theory. A lot of people have no clue that there's even a discipline called organization theory. I wish that I would have known about it when I had first got my first undergraduate degree, but I didn't. But in any event, I'm glad I learned about it because because I love it and because it's been my life work in the last 32 years. Organization theory is really simply the study of how organizations work, why they are or are not successful. When you look at the domain of organization theory, it is not just kind of a singular domain, but it has multiple components. Some people study individuals, and we talk about those as the micro-organization theorists, or people who study organizational behavior. People study job satisfaction, motivation, turnover. That's really a micro-level kind of discipline, I guess, part of the discipline. And then there are meso-organization theorists, and the meso-theorists study group dynamics, team dynamics, the organization's effect on teams, the team effect on the organization. And then macro theorists really study the organization as a whole and may study industries. And I put myself in the meso and the macro side of things. And so the kinds of problems or issues that macro theorists would be thinking about would be the issues of organization design. How should we create systems to enable organizations to do their best, to be able to achieve high performance? Organizational culture, that's a more macro issue. Organizational learning, organizational change, those are things that I would be studying, and I have. When I think about safety and patient safety through the lens of an organization theorist, I think about healthcare as a special case of safety. It is safety that occurs in complex, dynamic, uncertain environments. I would say that most people in medicine or healthcare would think about it as the other way around. That safety is a special case of medicine or healthcare, but I think that's not the case. And I'm not the only person, because if you look at it, the Institute of Medicine actually, in To Err is Human, made the same point. Medicine isn't unique among high-risk, high-reliability industries because it is concerned with trying to prevent, detect, and recover from mishaps and accidents. And so I don't think I'm wrong in how I think about it. So let me just move on to talking a little bit about what are the theoretical underpinnings of my research in this domain of patient safety, and then give you an example of some research that I've conducted, and then talk about where we go from here. So when you look at the organization theory underpinnings of what contributes to high performance in complex systems, the literature on that really started to develop in the 1970s and the 1980s. And there were two major theories that were derived in that time period. And one was called normal accident theory. The other was called high reliability organization theory. And normal accident theory was a theory that was propagated or developed by Charles Perrow. He was a sociologist. He had studied nuclear power and 3 Mile Island, the accident there. And Perrow's thinking, this normal accident theory, his first book I think was published in 1984, Perrow said that accidents will be normal in tightly coupled and interactively complex environments. That it is very difficult to understand all the ways that things can interact and go wrong in complex systems. We simply don't understand everything enough. And there are many ways for things to interact and go wrong. At the same time that Perrow was doing his work in New York at Columbia, there were a group of researchers on the West Coast at Berkeley who actually came up with a thinking that was, a little bit differently. They saw things a little differently. Researchers at Berkeley came up with a theory that was called high reliability organization theory. And the thinking there is that in some situations, organizations and industries are performing remarkably well. These were 3 different researchers with different backgrounds. It was a scholar from public policy, a scholar from psychology who was in the business school, and then an engineering scholar. And they were studying a wide range of industries that perform remarkably well despite trying conditions. Typically, when we think about high risk, high hazard industries that perform well, highly reliable industries, we think about commercial aviation and air traffic control, we think about nuclear power, and we think about naval aircraft carrier operations as the gold standard of these kinds of organizations. So the underpinnings for my work really comes from these kinds of theories, and they were really kind of the basis for the formative ideas underlying how I see safety and underlying the kinds of things that I think we should be studying when we're studying the issue of patient safety and harm in healthcare. The first idea is really that organizing in particular ways matters. That organizing in particular ways, and how I mean that is just the way that we set up our systems, how people are interacting, how people are doing the work, the kinds of things that they're doing, that can decrease vulnerability, and it can increase the capability to manage things that you weren't expecting. Organizing can build systemic alertness and awareness, can help people make sense of what they're facing. It can give them capabilities to understand how the system is going wrong before it goes wrong. Because we know that if you see things earlier in the making and the unfolding of problems, you can take actions earlier. Because when you look at the literature about adverse events and crises and catastrophes, what do we see? We see that sometimes they're a result of inaction or the wrong action or execution or performance. But more often than not, the origins of these catastrophes and these crises and smaller errors, big errors, those kinds of things, more often than not, it's a question of misperception, misconception, and misunderstanding. People didn't see the details. They didn't understand what those details meant. And so they really then didn't prepare, or they didn't act in ways that would help them from going wrong. This also comes, these ideas come from the work of Marianne Paget, who was a sociologist who studied medical error and studied doctors' decision-making in the 1980s. And if you've never looked at it and you're interested in patient safety, I love Marianne Paget's work, who unfortunately, she died from a medical error, which was really interesting. It was a misdiagnosis of a tumor that was eventually killed her. But as Paget pointed out in her work, in her very intensive work, things go wrong in medical work as a matter of course. Mistakes become apparent as events unfold. Actions become mistaken over time. And so alertness and awareness, I think, is critical, and I just want you to know where I'm coming from. So what do we see in these high reliability organizations, or what do we see in high hazard organizations that are performing extraordinarily well? We see a number of things. Number one, we see that they have dual operating logics. There is a logic of anticipation and there is a logic of resilience, okay? I'll say more about that in a second. These are organizations that spend a lot of time making sure that they are enacting the best high-performance human resource practices. And in addition to the fundamentals, these are organizations that have or think about anyway, having the best task and work design, having great technology, and really making sure they're on the cutting edge in their industry of how you do things. But they also are very concerned with human resource management, and that is they pay attention to selection. They're thinking a lot about selecting the best people, not just for expertise, but selecting people on the basis of their interpersonal skills. That is a more recent kind of thinking that interpersonal skills matter. They are critical to assuring high performance and highly reliable performance. These are organizations that pay attention to mentoring, They have formal mentoring processes. They train, 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 and train because they understand that people have to keep building their repertoire of skills so the organization can develop a large repertoire. And finally, they also understand that they have to make sure that people have opportunities to exercise discretion so they can build their capabilities to make decisions. These are organizations that spend a lot of time thinking about the social relational kind of culture and climate that they want to create. They know that trust and respect is critical if you're going to create a system that is going to be alert and aware, because anyone, anywhere, has to be able to think that they can speak up about something they see. These are organizations that spend a lot of time thinking about connecting people because they coordinate their activities, and so you want to be aware of what's happening upstream from you and downstream from you. And then these are organizations that engage in and develop a number of recurring daily practices and processes. We talk about it as habits of thought and action. So for example, daily rounds, huddles, handoffs, rapid response teams, learning moments, etc. And they organize their activities around a number of key principles. They're preoccupied with failure. They want to understand the system. How are things going wrong? What has gone wrong? We understand our system better if we do an analysis of these kinds of things. They know when people organize, they simplify their views of the world. When people get together to coordinate their actions, they move from perception by, or knowledge by acquaintance to knowledge by description. You move from perceptions to conceptions. In order to talk about things, we come up with labels, and sometimes those labels are not very diagnostic, or they're not as complicated as we need. These are organizations that spend a lot of time thinking about, what are we facing at this moment? We're facing this. It means that we need to make some adjustments to make sure that we're not going to screw up later on. These are organizations that spend a lot of time thinking about and anticipating what could go wrong, but they know things are going to go wrong, so they create resilience. And they're very enamored with authority and hierarchy, like all organizations. But they loosen the designation on who is the authority when they're facing high-tempo times. So decisions migrate to people who have the capabilities and the knowledge and the expertise to solve the problem. So let me just say a couple words about anticipating and prevention. We know that most organizations, most industries, have worked diligently to improve their ability to forecast, to anticipate, to prevent things from going wrong. They have a number of activities to do that. But we also know that in order to do that, you have to really understand what you're facing. And in very complex systems, you don't necessarily know all the ways that things can go wrong. So it is hard to develop routines and standard operating procedures and contingency plans if you don't understand everything. And I would say that is probably the case for all organizations, which means that, you're going to be surprised. Always going to be surprised. You can't get that surprise behind you, because things that have never happened before happen all the time, meaning that you're going to continually see that, which means that you have got to build a capability for resilience and containment which these organizations are doing. I just think about resilience as the capacity and process to enable people to absorb strain and to be able to cope with whatever is in front of them. And from my perspective as an organization theorist, I think that means that we have to build systems to make discrepancies and make harm, things that are going wrong, visible, so people can act on them. So we can do all that we can to anticipate and prevent, but we know things are going to go wrong, so we have to develop the capability to catch problems in the making and to cope with what we see, which requires building people's capabilities, because if you don't have a capability to deal with a problem, you're not going to want to see it. And so there is a link between cognition and action is really critical. So when you organize in particular ways, what do you get? Well, I think that we get an operating system that enables widespread intelligent wariness. When people are intelligently wary across an organization, they are more likely to say, oh, that's a developing thing over there. Let me see what's going on. We hope that these are ways that enable people to develop capabilities to cope. We know when we look at what's happening in these high hazard organizations that are doing extraordinarily well, that it is not just a matter of creating standard operating procedures and having people act in the same way each and every time. We know, and what we see in these organizations is that they are continuously managing fluctuations in the performance. So they are changing the way that they work, even though they have routines, because they have to deal with new situations that are in front of them. And so they're always thinking about that, and of course, thinking about how they can learn from feedback they're getting. So let me just give you an example of the kind of study that you would see from an organization theorist who is interested in patient safety. And this was a study that I did with Timothy Voges, who is a professor at Vanderbilt University. Tim was one of my doctoral students at Michigan, and he is now like a rock star in patient safety, and I'm incredibly proud and thankful to have the opportunity to work with him. But this particular study, the questions were, to what extent do hospital units engage in these kinds of practices that I'm talking about? And what is the relationship between safety, we call it safety organizing, and medication misadministrations and patients' falls? And it was a study that was conducted in a private nonprofit U.S. health system, and we looked at 13 hospitals. They were rural and urban, big and large. Big and large is the same thing. They were small and large. We gathered multiple sources of data, interviews, and survey data from nurse managers and RNs, and archival data about the incidence of particular patient falls and medication misadministrations. That was in the 6 months after. And we did a number of analyses. When you're doing research of this sort, you have to be very careful, of course, in how you measure things. And so we spent a lot of time thinking about the psychometrics of our measures, and in fact published a paper on this particular, creating this particular index of safety organizing. And we actually, that now has been also validated in studies in Europe and the UK. And so we published several papers out of this. This first paper was a methods paper about how we created the scale. The second paper was looking at what the findings. And what we found is that, well, first of all, let me tell you about what you would see. I mean, these are the kinds of things that we were taking a look at. We were trying to assess and understand the extent to which the units in these hospitals were engaged in these kinds of actions. So talking about mistakes, ways to learn with them, thinking about when we're giving a report, being very conscious about what people need to look out for, thinking about activities that we don't want to go wrong, having a good map of who knows what, the expertise and the talents, and discussing skills, thinking about errors and going back and trying to understand what went wrong, how they could have been prevented, discussing alternatives to our work, etc. So, as I said, we created a scale, we validated it, it was very good psychometrics, we published a paper on those psychometrics, and then we tested the extent to which, if a unit was engaging in these kinds of behaviors, in the 6 months after, would they have fewer medication misadministrations and fewer patient falls? And what we found is that there was a pretty big effect. And now we know this is a gross measure, of course it is. Social science and all science is gross, but in any event, or fun, whatever. So in fact, what we found is that the units that there was a 29.2% reduction in medication misadministrations, and there was an even higher reduction in patient falls on those units that were engaging most in these kinds of behaviors. And in fact, what we found, the overall findings were, first, that units varied greatly in the extent to which they were organizing for safety. Number two, that there was the general finding that the more that these units were acting in these ways, were organizing in these ways, the better their outcomes. But there were two other findings that I think are really telling for what I started with earlier in helping you understand what I see in these organizations. Number one, the units that were using standardized care pathways, that mattered. That if the units were engaging with these standardized care pathways and they were also high on safety organizing, that they had even a better outcome than the other units. And the second thing is that the units that had a strong degree of trust in their leadership and also engaged in safety organizing, that they had better outcomes as well. Two ideas going back to, as I talked about, this logic of anticipation. Here we see both the logic of anticipation, this idea of standardizing what we can, because we know, some situations you can standardize, other situations you can't. Standardized stuff can make a difference, but also we know that creating a social climate of trust and respect is also matters, and engaging in these safety organizing. So what are the implications, I think, for patient safety? I think, number one, organizing matters. I believe that safety organizing, or thinking about organizing in particular ways, can create an alertness and an awareness across organizations that enables us to pick up on things that are unfolding in a negative direction, and to catch and cope and correct before things go bad. And I think that other research has shown the same thing, and we say particular practices kind of may provide the behavioral underpinnings for a culture of safety. Let me just move forward with, what are some implications for future research? I just think that this stuff's going to become more important. Why? Several reasons. If you look at, and I believe that a colleague from Michigan, Amir Ghaffari, is watching this online. I'm hoping he is, because he wanted us to stream it. So anyway, anyway, we wrote a paper that was published in the Harvard Business Review 2 years ago. And it was kind of based on this idea that if you look at surgery has really gone through several waves of innovation. There was a wave of technical advancements, new techniques, new ways of training people, etc. Then there was a wave of standardization, the idea of implementing process improvements and checklists, etc. We think it's moved into a wave of organizing and thinking about how people organize teams, etc. Why it is this, and why I think it's going to be even more important, is some work that Amir and his colleagues at Michigan, they were all at Michigan at the time, published a few years ago on something called failure to rescue. We know research shows that high and low mortality hospitals have similar surgical complication rates. Generally, people would say, a high mortality hospital, you would think they're making more complications than a low mortality hospital, but that's not the case. Their complication rates are very similar. What high mortality hospitals have is a high probability of failure to rescue. That's kind of a mouthful, because I like to think about rescuing rather than failure to rescue, because I'm seeing the positive side on rescuing. So, in my view, if you're thinking about how do you rescue, you need to timely recognize and make sense of the conditions that you're facing. And then, of course, you have to intervene in some effective way. So from my perspective, rescuing, how is that enhanced? It's enhanced, by creating bundles of human resource practices, hiring the right people, of course, training them and giving them experience, and also creating this social context where people feel like they can speak up, and where people feel respected if they do speak up. Trying to build vigilant coordination and then engage in particular practices. All of these things, I think, can enable rescuing. And frankly, I think that research in the domain of these areas is really going to be growing in the next few years, because I think this is where the action is. Okay, so I think that organization theory is foundational to understanding safety's basic mechanisms. Okay, in my view, I think we have jumped too quickly to solutions. And so I think that we need more basic research, like the kind of research that I'm doing and talking about, because why? Safety is a dynamic non-event, that it's dynamic in the sense that it's preserved by timely human adjustments. And it's a non-event because when things are going well, nobody's really thinking about that. It's when things go wrong is when you really pay attention. I believe, and from what we know in organization theory, that we're never going to have a complete understanding of all the things that go into making systems reliable and safe. We can't know that, okay? Doesn't mean we can't study it, but we can't know it. I think system safety is an illusory concept. I think there are no safe systems in organizations. Why? Because every day is a new day. Just because you had a good day yesterday doesn't mean a good day is coming today. These are transient systems. They have to be continually reconstituted, and you do that every single moment, okay? And of course, we know that adverse outcomes are rarely the result of a single action by a single individual or the result of a single cause. So what does that mean? These are the things that I think we should pay attention to in the future. Culture is something that has been brought up over the last 20 years as the cause of every problem in the world. You just have to look at the front page of the newspaper. It's not just in healthcare, it is everywhere else. Every single bad thing that has happened in the last 20 years is a consequence of culture. Okay, well, it can't really be a cause of everything and a cause of nothing, but in any event, culture in safety is a big deal. All organizations are doing culture surveys, but when you look at the literature, what do we know? We know that people have spent a lot of time trying to measure culture, which is fine, but there aren't a lot of studies taking a look at what culture affects or what are its outcomes. So we definitely need more attention there. That's an organization theory issue. Incivility. Incivility is rampant in organizations. It is just being picked up now in healthcare. What do we know about incivility? Research shows that incivility affects not only people's cognitive capabilities, but it also affects their procedural capabilities, even if you're a bystander. And we also know that if it affects the extent to which people are going to speak up in organizations. And speaking up in voice is really critical. So we need more work on incivility, particularly how it's affecting people's capabilities to do their work. So power and voice. This is a little bit of a, I think this is a really big deal. In healthcare, what have we done? Healthcare has focused on, I know our time is getting up, but I'm almost done. Okay, so healthcare, we've been focusing on making sure that people on the front lines want to speak up, trying to remove barriers for people low on the totem pole to speak up. I think it's the wrong focus. In my view, we should be flipping the focus, and we should be thinking about to what extent are high power people actively inquiring of lower power people, and to what extent are they listening? I want to know about that. So I think that's really important. Gender, I'm just going to say this. In my work, I found that gender in safety is becoming a real issue. Women are doing it. And I think we need to think about what are the consequences of that. And finally, resilience. In particular, I want to think about the downsides of resilience. Healthcare organizations are remarkably, remarkably resilient. And what happens when people are resilient? I mean, resilience is a good thing, don't get me wrong. But when systems are resilient, it means that leaders think, well, they're making it happen. And so we are unlikely to dig into the problems. And so I think we need to think about that as well. So let me just say a couple final thoughts. My collaborator, late colleague collaborator, Bob Weirs, we have a forthcoming book coming out next year. It's called Still Not Safe, The Patient Safety Movement and the Rise of Bureaucratic Medicine. And it's going to be really popular. I want you all to go. I mean, our first title was Still Not Safe, The Rise and Fall of Patient Safety, but we made it a little spicier. But in any event, it will be published next year by Oxford University Press. And in that book, Bob Weers and I note that the numbers of scholars studying patient safety from outside of healthcare and medicine, I think, is really going down. I think it's dwindled over the past 20 years. In the Institute of Medicine report in 1999-2000, the Institute of Medicine said, we've got to draw on theory from outside of medicine. And at first, patient safety circles were crowded with people from outside of medicine, people from organization theory and psychology and engineering. But over the years, the last 15 years, Bob and I counted at particular conferences the number of people from outside of the discipline of healthcare. And they were getting really, really small, okay? I think that's a problem because, I think we can only make progress if we're working across disciplines, and especially on complex problems. And I think that's why I give the Provost's office and the president, and the BDP program and all of the transdisciplinary initiatives that they have started, I give them kudos for doing that. I think it's the only way that we're really going to make progress. And I like to think that I'm doing my small part in creating knowledge about how we can make healthcare safer, and I look forward to continuing my work and to any questions for like 1 minute, or you can just give me your questions online. So, yeah.
Amazingly inspiring. I've learned a lot. We do have time for questions. It's just too important.
Thank you for the stimulating lecture. Now, I know some doctors tried to run airlines, but they failed. I wonder if you have given thought to the safety in the airlines versus safety in medical.
Same question.
Yeah. So whether
Because the number of accidents in airlines clearly
have gone down.
Any lessons learned?
Yeah.
Just
I think that the surgical example, the idea that first of all, it took airlines 30 or 40 years to get to the point that they're at now. And it was a combination of things. They started with technology. And if you think about the surgical example, I think that the idea that it's gone through waves, I think that the technology came first, improvements in that, and then there was a big improvement in the way that people were trained in crew resource management and how people interact. So all of those things are making a difference. And when you look, what's so interesting to me is when you look at high visibility airline accidents, what do we see? We see that there are issues of attention and perception, conception, and understanding, and issues of teamwork. And so, yes, we have learned from them. That's where a lot of the research comes from, and I think it is vigilance and looking, really. So, okay. Anyway, okay.
Thank you.
Yeah.
Similar question regarding policing and law enforcement. Do you see obvious connections and an appetite for people to act on those connections?
Yeah, that's it's a really great question. I have not studied policing, although I've thought about it. I think it's an incredible context. I think there are connections that I would see because I think there's a lot of issues related, first of all, to coordination, teamwork, and issues, dynamics like that. I think the perception and conception, this alertness and awareness, I think is really, really important. I do some work with the Fire Department of New York. That's as close as I get with policing. And even though, what I found is that they're very receptive to these kinds of ideas of creating this alertness and awareness because every day is a new day and, challenging, complex situations. Thank you. I really appreciate the opportunity to talk with you today. I'm happy to answer questions by email, and I appreciate your being here. So,
Wow.
thanks.